content available for us to do things during the pandemic. So I'm happy you chose us and me as your entertainment and educational outlet for today. Uh, we will have about a 50-minute presentation, and then there'll be time for open Q&A as well as texting of questions that you can see on your screen as well, and we encourage your participation. This is an independent CME activity jointly provided by the Postgraduate Institute of Medicine and Viral Ed with funding from Viral Ed. I am the chairman of the HIV Steering Committee for Trio Health, the director of clinical research in HIV and HCV at the Washington Health Institute, where I see patients. I work in Washington, D.C., and I also work at the Department of Health doing work with prevention and prevention research in our STD program. Our target audience today is you guys, providers, physicians, physician assistants, nurse practitioner, nurses, and any other healthcare practitioners involved in the care of patients with HIV. We encourage you to understand some of the ways to individualize treatment approaches towards patients and also some of the unique aspects of things in the South. And I think you'll see that in the context when we start to present our presentation. This has been approved for 1 hour of AMA Category 1 credit. And for pharmacists, for nurses, and all providers, it's available. So please fill out the feedback forms at the end, which is how you'll get your credit at the end of the activity. The course director and faculty is the illustrious David Wohl, professor of infectious diseases at UNC at Chapel Hill. I'm sorry David's not with us because he's an excellent presenter, but I hope I can channel much of what he wanted to help you all learn about and some of my own perspectives as well. There are conflicts of interest that I need to talk about. David had the following ones, and I have the ones that are listed here. I do consulting for both Gilead and ViiV, and most of my work is done with those two companies, and I've done a little bit of work with Merck as well. There will be potential unlabeled use, and that we don't think that any of the things that we've been involved with has influenced our development of the content today. And if you all feel any differently, please report that in the feedback system. We try to be as objective and above all as helpful. We are working clinicians. You all are working clinicians, and our goal is to make this beneficial for you all. Please mute your line for the entirety of the program. You can ask questions in the Q&A messaging box, which will appear to me in real time. For those questions that I can help do in real time, I will, and the others will do at the end. Following the program, you'll receive an email with instructions to fill out the post-test evaluations. Please do that. We're just rolling these series of talks out. They include information that was presented at the virtual CROI meeting, and the self-report is also included to help you claim your program certificate so you can get your CME. So we're going to start with the word of the day, COVID-19. Then we're going to get to potentially 3 cases. I would be surprised if we get to all 3. I'm going to shoot to get to at least 2 plus the COVID sections. So the information around COVID-19 is changing. I'll try and speak to anything that is relevant that's changed since we've done this documentation. This is changing literally every week, as I'm sure you all are completely aware of. The first thing is that with HIV, we're not seeing, we don't really know yet if HIV is very different in regards to COVID than non-HIV. We are suspicious that people who are virologically suppressed and decent CD4 count are going to have similar susceptibility and clinical outcomes as COVID, and there might be some reasons to think otherwise. There's been some data to show that with lopinavir and ritonavir, you saw decreased mortality, though not a change in clinical conditions, and so there may be some role there, and there's also some issue around perhaps tenofovir or Truvada might be or TAF even could be beneficial, though the jury is clearly not in. The biggest things I want to talk about, though, is that really what we should try and do is not treat our HIV patients differently than we would our HIV negative patients. People with HIV should plan for at least a 30-day supply of all medications, having some extra medications available. Make sure vaccinations are up to date. Most sites are working aggressively with telemedicine. They're still having some availability, so vaccines can still be given, often can be given at pharmacies, depending on some states. Talk to the patient about what your plans are. I think we've had a mix up sometimes in that we're doing telemedicine and patients come into the office and the doctor's not there. They're sitting at home in their office connecting through the internet, and the patient comes in to see a real life person. So make sure everybody understands that. There's a lot of things that go along with the establishment of a telemedicine plan. It's going to be different for each person's state. The CMS and AMA have changed a lot of the criteria for that. So now that video, along with a necessary depth, is enables you to do the same kind of billing with a CPT code without a physical exam. So these valuations are not meant to be a financial loss. Often you need to combine video with that, and so in some states there's a need for a consent form for a video for patients to be included, to be integrated into that record. And so you have to check on local rules about that. Clearly, folks with concomitant disease and comorbids are more at risk, but as I said earlier, there's not any data developing right now to suggest that HIV is part of that. There's been 2 studies that have looked at this, one in Germany and one in New York City, and they did not show increased risk. If anything, they showed a little bit higher risk for people with lower CD4 counts and people with higher viral loads, suggesting that there would be some immune dysregulation, which then causes immunocompromise, which of course can predispose people to a little bit more of a risk for COVID and worse outcomes. But in general, patients who were controlled on therapy were not seeing those same kind of issues. When hospitalization is not necessary, I think the same symptom management. I think we don't need to approach with a higher index of suspicion the chance that patients are going to get worse. So I think maintaining close communication if symptoms progress. Be aware there are 2 phases in COVID-19. There's the initial phase, which really looks like an acute illness, and the second phase, which is more characteristic of what we talk about as the immune storm or a cytokine release storm. And it's that second wave that I think is causing people to get in trouble and to be careful, as well as we know that this group is more likely to have thromboembolic complications. Untreated HIV, and to some degree, it's questionable whether treated HIV has thromboembolic complications, is certainly a relevant risk factor to think about when you're evaluating patients with COVID-19. So continuing them on their ARV therapy and other medications as prescribed. There's been a lot of discussion about whether ACE inhibitors or ACE blockers are causing improvements or declines, because we know that the receptor for COVID-19 is also an ACE2 inhibitor, and I think that the data is not clear on that yet. So just continue people with patients with whatever their current regimen is to hope that you'll be controlling their comorbid conditions, and that's really the best course of action currently recommended. So I think whenever possible, have at least a 30-day supply and request 90-day supplies. Certainly going mail order so patients don't have to go to the pharmacies is advisable, but not essential. There's no indication right now to think that any of the ARVs are more active against COVID, so there's no reason to change them. And clinicians for caring for people who are dealing with opioid treatment programs, which is one of the big concerns about declines in visits with telemedicine, that we could destabilize some of the opiate care we've had, and opiate substitution programs could be impacted by this. Should contact the SAMHSA website, the Substance Abuse and Mental Health Service Administration website, for updated guidance on how to avoid treatment interruptions and then how to manage them. I think this is a critical area right now that's threatened by the transition we've had to telemedicine. So learning how to navigate that is very, very important. In general, we're deferring face-to-face visits only when patients have to have a physical exam. And it's amazing how many things now with telemedicine we're able to use. There are devices that can do all the vitals at home blood pressure monitors, home oxygen saturation, can give you blood pressure readings, can give you respiratory rate, can give you PaO2. So aside from palpation for pain, which you can sometimes do with patients on video, there are other approaches now that can give you electrocardiograms and give you programs like that over the telephone or over the web. There's quite a lot that can be done through virtual visits, and I encourage you to explore those tools and encourage patients to access the tools when they're appropriate. When a patient with HIV is hospitalized, clearly continuing them on their uh, ARV medication. For patients who require tube feeding, some medications can be given either in liquid form or crushing the pills. And if you're not sure the best way to continue that in that setting, make sure you're contacting the local pharmacologist or HIV specialist to understand exactly the best way you could use that at your clinical setting. And I do want to welcome and appreciate all the people who are coming on to the session. We're glad to have you, especially a holiday edition of Viral Ed here on Memorial Day. So far, we've not seen drug shortages. One of the concerns is that people would need to like stock up on their meds. There'd be a decline in raw materials. We wouldn't be able to get medications. We wouldn't be able to get beef. We wouldn't be able to get mixers. We couldn't eat, drink, or get medications. Thank goodness those fears, which all of us have felt, have not really come to pass. And drug shortages have not occurred in the currently. NASDAQ has remained in contact with major manufacturers as well as drug distributors who have products that relying on ingredients produced in China. And as of the beginning of this month in May, there were no reports of any supply shortages of these medications. PPEs are a different story. Those are certainly coming online now, but medications have not been challenged so far. There may be additional assistance with people coming to the home to do ancillary services. Those are more vulnerable. And I think it's those sort of more complementary services that we offer rather than direct medical care that are really are threatened. I think one of the underlying things that I don't think we've really had a close look at is what's the impact of social distancing going to be on mental health and consequently the impact of mental health on adherence. I know that in my practice, it's really improved a lot since we've had video conferencing. Patients thought they wanted to do audio alone, but video really helps make the contact. And it really helps for the patients you've had before that you know to help them feel like they're not alone. There's so much isolation right now and how that impacts everything about the way we live, the way we feel, the way we take our medications is something that we have to look at to the same degree as we look at all of the other threats of a comorbid disease, and I think respond to those appropriately. Not always easy to do, but I think really important. So with that in mind, unless there's any questions, I guess I could take questions Q&A if you have anything on COVID before we start into the current presentation. Are there any questions? Okay, without further ado, we can certainly answer any of those questions at the end. Let's get into discussions about HIV in the South. Let's talk about Bernadette, a treatment experienced patient looking at switching, and I think dealing with one of the most common comorbid conditions we're dealing with of today. Bernadette is a 27-year-old woman living with HIV in South Carolina. She is out of, her state has been reopened. She's able to go out. And she wants to know if she can be on one pill a day. She was perinatally infected. Her viral loads have been suppressed. She's on atazanavir, Cobi, and tenofovir and FTC. She had non-nuc and NRTI mutations that you see listed, but it's not affected her response to therapy, but she's on a boosted PI. She gave birth to twins a year ago. She's now had her tubes tied, and so she's not really at high risk for pregnancy. She's on hypertension, 2 blood pressure medicines. She's a non-smoker. She's back at work. She's afebrile, but with hypertension. But her BMI is 30.2. When you look at her other labs, you see most of them are pretty good. Her LDL is a little high, but not bad. Cholesterol is relatively normal. But the real issue here is she wants to switch. And she really wants to switch to a once a day. You could switch her potentially onto a once a day with a protease-based regimen. But she's interested in integrase, but she's heard things about weight gain. How would you approach that? Overall, when we look at obesity, you can see, for some reason, you see the least in Colorado And for some reason, DC has a low rate, which I'm glad to say that I'm part of, as well as Hawaii. Two of those three states, Colorado and Hawaii, have vigorous outdoor lives. DC, I really can't explain that finding. But when we look at where there's greater than 35%, you start to see along the Mississippi River. And when you look at the group of 30 to 35%, you can see a high proportion of the South and in the Midwest. So we know that in terms of comorbid conditions, the risk of obesity and the prevalence of obesity is high in these areas. This is an American problem before we got to HIV. When we look at the prevalence of these self-reports, looking at non-Hispanic Black adults, these numbers become much more sober. And you see all of the South as greater than 35% among African Americans, and almost half the country. So it's not just the South, but the South makes up more than half of the states that represent this greater than 35% for non-Hispanic Black adults. That means then when what we're looking at with our HIV medication superimposed upon an already existing high prevalence, hate to use the word pandemic, of obesity in this population, we've got to be very thoughtful and judicious as to how we look at the competing interests of controlling HIV and not exacerbating underlying comorbid conditions. We look here and we see the trends in age-adjusted obesity over time, and they're not going down. We look at obesity at BMI greater than 30. Once you get past 25, you have increased cardiovascular risk and increased risk of diabetes. You're looking at close to 42%. And then when you look at severe obesity, which is BMI greater than 40, close to 10%, almost a doubling in the last 10 to 20 years. So the prevalence and the incidence of obesity on the climb, very, very serious problem, a big American problem, well separate from HIV. When you then look at HIV prevalence, you start to see what almost looks like a superimposition, a superimposed map of some of the issues around obesity. North Carolina and Tennessee, and other states are missing data, but for the most part, this is very high prevalence in the South. And so this really raises a lot of concerns about both the commingling, the confluence of HIV as well as obesity in the South, and certainly worse so for African American patients. There are a variety of single tablet regimens that we can offer Bernadette, but you can see that of the 8 you see here, 5 of them contain integrase, and 3 of them contain non-integrase containing regimen, 2 with non-nuc and 1 with proteases. So it's clear that integrases would make up the bulk of her choices, but our integrase is the best choice for her. Let's look at some of the data surrounding integrases as well as surrounding NRTIs to get a sense of what the contribution is towards obesity in a population already with a high prevalence of these same issues. NA Accord lets us look at weight gain with ART initiation, and you can see that over time, people do gain weight because part of the startup phenomenon. You see it at a high rate in white males, non-white males, non-white females, but less in white females. And these numbers have gone up over time. This is a byproduct of what we could call a refeeding syndrome, where patients are beginning to not feel sick, and so they're able to start to get their appetite back and they increase their weight. But these age-matched comparisons are worse for women than for men. So not only are we dealing with an epidemic that's fueling both African Americans, but for African American women, this risk can even be worse. When you look at the rising obesity prevalence, you see that the numbers over time have increased amongst HIV-infected patients. And you can see that where this really you do see it starting to level out after years on therapy. But it's worse. The place where people started to gain the most weight, 2007, and then 2012 was approved then, and you don't really see that. So integrases clearly could be contributing to higher weight gains than we saw in the ages of PIs and non-nucs. A study presented at CROI, virtual CROI, that looked at these same issues was a study that looked at a little under 1,100 patients who were starting a dolutegravir regimen for 2 of them with either TAF and FTC or TDF and FTC. And the purpose there was to help delineate the contribution of TAF versus TDF in the presence of an integrase versus an old-fashioned regimen, efavirenz, TDF, and FTC, which had been the WHO recommended. The rationale for this study was really to compare efficacy at the time as well as changes in weight, because efavirenz had been the WHO guidelines prior to integrases being suggested as a substitution. So this study allowed for the comparison of the old versus the new standard, and also a difference in the nuke backbone to see if it made a difference in terms of weight. And study visit baselines were done frequently during the 96-week period, as you see below. Open label studies where patients knew what they were getting. And the advanced study results are pretty clear here. And women, especially women on a TAF, FTC, DTG regimen, gained the most weight. Next was a TDF, FTC, DTG, and efavirenz gained the least. That same approach replicated itself in men, but was truncated. In women, you saw a weight gain after 96 weeks of close to 8 kilograms in the TAF arm, compared to in men 5 kilograms. About 6 kilograms in the arm on TDF DTG over 96 weeks in women, compared to 4 in men. And efavirenz in women, you saw a little under 4 kilograms over 96 weeks with TDF and FTC, compared to 1 kilogram for men. So clearly, gender-based differences in response to weight gain matter. And whether they matter in particular for specific agents, either integrases or non-nukes, appear to be borne out in this study. When you look at the changes in obesity, in treatment-emergent obesity, so a change in BMI class, you can see differences here in the regimens, which a much higher prevalence of a move to a higher BMI in patients on TAF, FTC, and DTG compared to certainly to the other regimens. And you see less with TDF, but the least amount with efavirenz in women. And you see the same pattern, though severely truncated in men, showing again a real gender difference. And so you get a sense that these differences certainly have a significant component of gender. The rationale for that is not established yet. When you look at an analysis of a variety of studies looking in double-blind placebo that have been presented by Paul Sachs in CID in 2019, where they looked at close to 6,000 patients in 8 different randomized clinical trials. And they looked at the differences between regimens. They looked at the differences between genders. And granted, what they could do was limited to the 8 RCTs they showed. And they're listed here, not in terms of number, but some of them were 2 of the same. What they showed, I think, pretty clearly was that integrases were if you looked at bictegravir and dolutegravir, there were very little differences in weight gain, with less with elvitegravir. And when you looked at the differences between race and gender, Black females and Black males gained the most, and non-Black females and non-Black males didn't gain the same amount of weight gain. And the factors associated with weight gain in the multivariate modeling were lower CD4, higher viral load, no IDUs, female sex, and Black race. So a confluence of the demographic factors we talked about, Black race and women, as well as an immunologic component for people who are gaining weight, because they probably had that refeeding that we talked about people starting to gain weight after they'd been unable to eat because of immune compromise or perhaps low-level disease with immunosuppression. When you looked at the treatment component arms, integrase, DTG, and BIC more than elvitegravir, non-nukes, rilpivirine more so than efavirenz, and nukes, TAF, greater than TDF, abacavir, AZT, all were associated with increased weight gain. So we come back to Bernadette, who says, well, great. I understand that because I have an elevated BMI, because Lord knows you don't want to say you're necessarily overweight, but obviously you'd have to say that in a empathic and caring way. And then how would you talk about the concerns about switching to an integrase? Would these concerns be so much that you wouldn't switch? Would you consider switching to a different regimen? Would you tell her to stay on what she's on because she's doing okay? Those are the clinical questions that are apparent here. Now, we talked about these differences already. So you know that there are regimens like non-nukes that are going to be less associated with things you could switch her to. The demographics she can't change. So the real question is, would you switch it to an integrase or would you switch it to a non-nuke? If you're going to switch it, would you switch it to a nuke-sparing regimen because you want to avoid TAF and you'd be okay with TDF, abacavir, AZT, or would you want to look for a nuke-sparing regimen altogether? When we look at the data on the use of TAF alone, and the only data here is looking at 96-week data, where we're looking at those patients who in Discover, there was a PrEP study. So this was a study done with MSM or transgender women that were randomized, about 2,700 patients in each arm who were only on TDF or TAF. And what you see here is at the end of 96 weeks, there was a 1.2 kilogram, or about a little under 3 pounds difference over 2 years. And when you looked at this change in BMI, very minimal. So this would suggest that the role of TAF alone, not in combination with others, is accounting for a small amount of weight, but nowhere near the amount of weight we saw in some of the advanced studies where you saw 8-kilogram rises. On the other hand, this study is only looking at MSM or transgender women. So this data can really only apply to that population. Women are not included in this study. So if gender is really driving this differences between NRTIs, this data does not comment on that difference. In DAD, when we looked at 43,000 patients and looking at what were some of the biological consequences of this risk, the impact of short-term BMI changes on CVD events was not seen. And diabetes was evaluated as a control measure because they thought that might be something more likely to be seen. And what they showed is when you looked at the CVD events, if you had a BMI decrease of greater than 2, in a BMI less than 20, you did have a higher rate of CVD events. But in the other ones, it was very close to no difference. However, in diabetes, and these were adjusted for other risk factors for coronary disease as well as diabetes. In diabetes with an increase in weight, you can see here significant increases here as you saw increases in BMI rates. And so what we're seeing is that the impact of this weight gain is at least first seen on the risk of diabetes and not yet seen in the risk of coronary vascular disease. So that's the take-home message there. So we come back to Bernadette, who wants to understand, well, you're telling me that TAF didn't affect men, but it does affect women. You're telling me that integrases affect women worse than men. So what are you telling me, doctor? What should I be doing? We know that in terms of the ability to say that this will be virologically successful, we can give her very comforting news. This is a patient looking at patients who were self-described as African American or mixed race, at a viral load less than 50, EGFR greater than 50, a 2-to-1 ratio to be switched onto a BIC TAF and FTC. And you can see that these patients had some amount of resistance, an NRTI resistance about 20%, M194V about 10%. So there's always been some concern about how robust is a patient switching off of a protease regimen that we know can still lead to suppression with an M184V compared to the ability of an integrase to do that. And this study looked at that question and found, lo and behold, very successful. In patients who had any resistance, great results. NRTI resistance, great. No difference when you switch. So very comforting in terms of the rates of virologic suppression. Another study called Dawn looked at this in a different way. In this study, they compared comparison of DTG and 2 nukes to lopinavir ritonavir and 2 nukes. And in these patients came in who could have had viral loads less than or greater than 100,000. These were patients who were not succeeding, and they had virologic failure, at least 2 instances where the viral loads were greater than 400 on their first line NNRTI plus 2 nukes. So, and they had no primary resistance to integrases or PIs. And so the idea is which works better. So this is for a patient who's switching, but a patient who's switching who's not suppressed, different than what we saw in the last case. And what you see here is that in dawning, you had much greater success with the patients on DTG than you did lopinavir. And in fact, there might have been 2 cases of resistance that you saw in the DTG arm, but not in the lopinavir arm. The clinical success of this that was greater with integrases gave most people the sense that integrases were the way to go. And this just goes to show you that across a variety of patient classes with different forms of resistance, you still had a better virologic rate of suppression with DTG compared to lopinavir. The same thing was true with when looking at treatment differences with tenofovir with the K65R. That was the only clinker that the use of that, which still is very uncommon. It doesn't make sense to use TDF or TAF in that setting where you've got a K65R. So getting back to Bernadette, she switches to BIC, FTC, and TAF, and as we just expected, her viral lows stay suppressed, but she gained 10 pounds. What would you do now? So doravirine and other non-nukes are becoming certainly a more and more switch data showing their success rate. Here's a study that I participated on looking at change in body weight of doravirine, and this is looking at patients who were on doravirine as well as switched, and you see low rates of weight gain, very low rates overall, suggesting that doravirine performed just the same as boosted darunavir or efavirenz when compared for any weight changes. And so giving you a comfort level about if you were to switch patients to doravirine, you're not going to see a big weight gain. And so that brings us to our discussion at the end of the day is, what is the best thing to do? And at the end of the day, you're going to have to talk about that with the patient. I have patients who certainly have switched to doravirine-based regimens. I have patients who stayed on BEC. I have patients who are on TAF, patients who are on TDF, and I have patients who switched off of nukes entirely. I think there's no clear clinical answer yet. And the issue about balancing the virologic suppression benefits of these regimens compared to some of the weight gains is ultimately going to be an individual patient discussion. So I'm going to keep moving on and talk about a patient named Antonio, and this is going to be about PrEP and about acute initiation. This will be our last case because I don't think we're going to have time to do the third, and then we'll have a little bit of time for Q&A. Antonio is a 31-year-old man called by the Department of Health because of an early diagnosis with syphilis. He's got 1 to 2 partners a month. He's very fluid in terms of his sexual practices, sometimes used condoms. He's got very good numbers, but he's got a high RPR. And you know that, and his HIV antibody 4th generation test is negative. He's got other STI testing that are negative. So he comes in with syphilis. And so is there any concerns about recommending PrEP in addition to treating syphilis? I would think for most of you, no would be the answer. No should be the answer, because clearly this fellow is having risk. He's having unprotected sex. And if this was his first event, yes, I guess we could hold off on PrEP, but this is clearly meeting a criteria for a threshold for starting PrEP. So it would be something that you could think about doing. You'll see here that he's got no evidence of acute HIV. One of the concerns here is that he's had a recent exposure and he could have acute HIV because the 4th generation test would only comment things in the last greater than 14 to 17 days. With patients who are coming in more frequently, the possibility of an acute HIV in that 0 to 21 day period after exposure with a negative 4th gen test is something that can occur and is something that you have to think about. So what would be the way you think about it so that you think of things to make sure that wouldn't happen? Well, the first is you look and see if they have fever. He's afebrile. You feel comfortable about that. Does he have any flu-like illness? He has no rashes, no lymphadenopathy, no lesions at all. His HIV test is negative. So you have nothing really to suspect acute HIV. If any of these things were different, if he had a flu-like illness, of course, there's COVID-related issues too, but a flu-like illness, myalgias, new rash after a sexual encounter in the last 0 to 14 days, all of those would alert you to the possibility of acute HIV. But here, there's nothing. When we look at the cascade for people getting into PrEP in British Columbia, you see that they had pretty good success getting people in, but the issues about non-retention as we start to deal with this are um, non-MSM risk, younger age people don't stay in it, no prior PrEP, which is everybody who starts, or providers that's not done it before. So these are all risk factors that we want to consider. Because PrEP is highly effective, we can get people to be compliant. And so the question is, how do we optimize that issue? When we look at the effectiveness in a different study, looking at HIV acquisition by PrEP status, you can see that folks who were younger had higher risks, that folks who were, for some reason in this particular study, you had patients not on PrEP with a higher percentage of white folks dropping off. And STD diagnosis, a lot of those patients were coming on to PrEP. And you see, for some reason, a higher percentage of people with gonorrhea and less so with chlamydia leaving PrEP. But we know that when they stay on PrEP, their incidence of HIV is markedly declined. PrEP is very effective in figuring out ways that we can optimize that. We know that HIV prevalence by county much greater in the South. And so the South is an area where you have a higher need and also a higher underutilization of PrEP compared to other areas. When we look at data from looking at dispensing information and claims data, you can see that PrEP patients were more likely to be non-Hispanic white, 45 versus 26.2, older, male, and not reside in the South. And when we look at the MSAs and the proportion of MSAs with a relatively low uptake of PrEP were concentrated in the South. The South, for reasons both of the patient population and I think also because of providers, are not having PrEP offered quite as frequently. Here's data looking at this relative uptake of PrEP. Red is the lowest uptake, blue is the highest. And in this area where you've got the highest prevalence, you see some of the lowest uptake. When we look at that, it's not just the patients, but it's the providers. An interview with 526 providers looking at how providers perceive risk or things about the patients show that primary care providers in the South are not really up to speed, which is why we're doing some of these programs, but I'm not sure that you all are the group that are not up to speed. Any group that's going out on Memorial Day to learn about HIV, I think, is not the group necessarily who's undereducated. You guys are already on top of things. But if we're teaching you something, that would be wonderful as well. And understanding that the issue about local HIV prevalence and the need for HIV screening and prevention practices are very, very important in this population that we know is is not utilizing PrEP to nearly the degree that they should be based on their higher risk and their lower utilization. We look at the experience level of clinicians, and you see in rural areas, which make up a lot of the South, there's a higher percentage of care given in rural areas, which we know is providers with less experience. Again, setting up the perfect storm for a less experienced provider in areas of lower HIV prevalence where we don't, but still high enough prevalence to warrant PrEP, not receiving PrEP. So let's say Antonio comes back. He's got an HIV test that's negative, no rashes, afebrile. Would you use TAF or TDF? And the issues there is right now they're the same price. When it's fully generic, there could be price differences, but now there's not. So the differences really have to do, I think, with do they work the same? I think the data from the Discover study showed that there was evidence showing that TAF arithmetically worked better, but statistically they were non-inferior. So, but there's no question that it works at least as well, and reason to suspect there might be reasons to think it could work better. We can deal with that in the Q&A, but for now we're going to say that it for sure was non-inferior and works at least as well. We know that when you look at the issue around weight change, we didn't see big issues with weight change with TAF versus TDF in Discover trial. So for these men and transgender women who were utilizing this approach, TAF versus TDF, we didn't see a big difference. So let's say, and we know that there is some renal benefit and bone benefit, so that might have been why people would prefer TAF. In this case, however, Antonio, we change things up a little bit, and he comes back with a positive HIV test. You might have, if you were doing treatment on demand, you might have had a small amount of treatment he received over a short period of time. But it's always essential to have a good, at least antigen and antibody test. And when you're in doubt, getting also an HIV PCR for patients that you have any concern about acute HIV. Antonio, in this case, didn't present with any of those stigmata of concern, but you'd want to see that. So we got a question about some differences that I'll come to at the very end when I'm done this case. So one of the issues around PrEP, therefore, comes into what is the risk of resistance. In patients, in a study where they looked at 24, a little shy of 2,500 patients who were starting, where they did pooled HIV testing. So in other words, all the patients who started PrEP that day had their blood pooled. You found out who was positive, and then you went back to look at individuals. They were able to find 7 individuals out of 2,400 patients who started with acute HIV, a very low ratio. And all 7 of those had a genotype. And you can see that 3 of the 7 developed FTC resistance on PrEP. One of them developed this after 122 days on PrEP. So there, the problem seems to have really been that there wasn't exposure. The others, I would argue, were even still in violation, that they stayed on it for a month. In our clinic, where we get lab data, hopefully by day 7 of a patient starting on PrEP, we hope that we can intervene. But worst case scenario, where they were interrupted a month later versus 122, you saw these 3 cases that developed an M184V, and then 4 of the 7 cases did not develop. 1 of the 7 did develop a non-nuke mutation, which is a little bit hard to explain because they weren't given a non-nuke. So it had to be probably a transmitted resistance. So in Antonio's case, where you know that he's already HIV positive, the opportunity comes for a rapid start. And the idea of a rapid start here, there's been a lot of data on this at Crescent Care that's pioneered some of this, of patients starting in 72 hours. For most of you out there, a rapid start means you start as soon as you can. And they looked at differences in the demographics of those less than 24 versus greater than 25. Were there any significant differences? And the only thing you can see here is that HIV risk factors, there was a little bit of a difference in the group less than 24 and in the group greater than 25 in terms of p-values, in terms of the demographics of the population. The virologic suppression rates were excellent in both groups. You saw rapid suppression rates, meaning that the risk to the community during the time that patient's treated, especially if they're not using ART, is very small, but not a significant p-value. The virologic suppression out of 12 months, suggesting, are we starting people before they're ready? No, they were ready when they were told they needed to be ready, and their virologic suppression stayed high, and their rate of engagement over that period of time was quite high. We don't have data to compare what the rate of engagement would have been if they didn't stay, but we know that there's no risk of losing engagement in these patients that are starting ART initiation rapidly. So I think that leaves us with about 15 minutes left in the presentation. I'll take question and answers. I think there was one question, I believe, about differences in efficacy between TAF and TDF. And I'll say that there is no significant p-value to show there is a difference, though there was an arithmetic difference. And one of the questions becomes about why would there be such a difference? And it may have to do with the ability for TAF to load into a cell quicker and also to stay there for longer periods of time after a patient has ceased to take the medication. There may be more forgiveness in a TAF regimen. But currently, we don't have statistically significant data to show that indeed TAF was superior to TDF for PrEP. And so we can't make that statement. So there was just that tease of information, but more confirmation is necessary before we can really say that. Any other questions? Feel free to type things in or ask them. Our moderator can help bring your questions to the front.
Also, feel free to go ahead and take yourself off mute if you want to as well. This is a smaller group.
So Rick, what are you finding to be most challenging about doing the telemedicine piece?
I think that was Susan who asked that, if I recognize your voice. Hi, Susan.
Yes.
I think the most, I must say that the most challenging thing about doing telemedicine has been the red tape I had to get through till I could do telemedicine. My experience with telemedicine for my existing patients has been really excellent. The biggest problems have been that you never know which video format is going to work. We use an EMR that has a video format connected to it. I know other EMRs do that the same. And those video formats, some days will work flawlessly and other days will work poorly and not at all. I do find that it's really important to have a video component to the meetings. I didn't do that at first, and I really do think that's very important. And so there are other video formats you can use. Doximity, which is a site that you can join, gives you a video format that's encrypted end to end. Zoom has a now encrypted, that's HIPAA compliant form that's encrypted end to end. And so I've tried to utilize video formats that I know are HIPAA approved and encrypted end to end so that they keep things in guidance for that. So that's been one of the biggest challenges. The second challenge has been getting patients to sign consent forms in a virtual format. We've used electronic transmission document forms to do that, but our malpractice carrier suggested that we have consent forms if we're going to have video. So those have been the biggest challenges. We've encouraged the patients to come into our office for blood draws. We've arranged those blood draws at the patient. Our office is basically, in our clinic, is low volume to begin with. So for the patients to come in there and get blood, it's been quite straightforward. So that's been my biggest one. There was another question there from somebody about HIV risk. I didn't see that. CJ, can you send me that question back again?
Yes. Please explain the HIV incident risk index score from MSM for MSM.
It was just that in the that when you looked at the new cases of HIV in various populations, the risk in the MSM community was a higher incidence, a higher number of new cases in a given calendar time period than the same calendar period with a non-MSM group, so a heterosexual group predominantly. That's what that refers to. In terms of other issues around telemedicine, I haven't done a new patient visit yet, but I can tell you before I had video, I was doing a lot. I was working for the Department of Health, caring for COVID positive patients through telemedicine. And I found that people were so happy to have someone to talk to that as much as I prefer video, I can't say that I feel that the lack of video was a problem. We just had somebody raise their hand, so I can't see that, but CJ, could you help me?
I don't see that. If they typed something, it might have been just to you.
Okay.
Any other questions?
All right. If there's no other questions, you're going to be getting another case, which is a brief case that we can complete in the requisite time period. So I'll move on to that. This is a case of Miguel, a 42-year-old man in North Carolina, admitted to the ED to the hospital. This was a true case with a 1-week history of headache and confusion. Had a past history of hypertension and a motor vehicle accident, raised in Mexico, works in construction, has a very carefully curated diet of 6 to 8 beers a day. Somehow manages to stay thin, clearly doesn't have any of my family's genes. And he's awake, but he's slow to respond. So he comes into the ER with a dull sensorium. Blood pressure is normal. BMI shows he's thin. Oral thrush is dry. HIV positive, low CD4 count. Viral loads 22,000. So not on a successful regimen. And he comes back and you're worried about OIs with this guy because you can't understand why this would happen. and the labs come back positive for both comes back positive for toxo and negative for crypto. For some of us who've been doing HIV a long time ago, this is like deja vu. We thought we wouldn't see OIs again, but as we're seeing people get interrupted from taking medication, changes in healthcare law, and things like that, and perhaps with COVID, where we see less access to social services, we will start to see some of these OIs appearing again. And the South has been the perfect soil in a way for some of these changes, with poor insurance access in some of the states where you didn't have Medicaid expansion or very high threshold for Medicaid expansion, making the possibility that people will get immunosuppressive diseases again, such as toxo. This is a MRI of, I think it's an MRI, it could be a CAT scan, but I think it's an MRI, showing areas of lighting up of these toxo lesions. And we look at hospitalizations in the Southeast, and you can see that in general, this is looking at patients with CD4 less than 200, the 30-day readmission rate going down, but all hospitalizations still fairly high. Hospitalizations with CD4 less than 200 going down, and those with greater than 200, not insignificant. When we look at at UNC, what are the characteristics of that? You see MSM make up similar proportion to women. African Americans make up 60% of that. I don't know what percentage of the population there that's reflective of. And the nadir CD4 is less than 200 for people coming in the hospital. So this still, I think, is something that we have to think about, the risk of immunosuppression in that population. His CD4 comes back like this. His toxo is positive. And the question is, would you start him on ARTs right away? Or would you want to treat his underlying opportunistic infection? We know that in general, it's better to try and start him on in the hospital, not to wait. To wait and to delay things creates an unacceptable risk, because the chances that patients who come in, the subpopulation of patients who present with an OI, who get diagnosed in the hospital, the 24-month rate of viral suppression is poor. 40, less than half out of 12 months, less than 40% out of 24 months. You see linkage to care starting to decline, and then each subsequent measure of retention and viral suppression further declines. When we look at the issues around readmission, you can see here significant factors, a multivariate model of predictors of 30-day readmissions among these HIV positive. If they had elevated creatinine, if their diagnosis, they had a higher ratio of having cardiovascular disease. Looking at non-clinical, Medicaid, almost significant, but had a 40% increase. ED visits, highly correlated, meaning that they weren't engaged in care. Number of past admissions, again, highly correlated. Food insecurity, to go along with the way of living on the margins of society, highly significant. And issues around substance abuse, also highly significant. So this is the population, especially in this post-COVID world where we start to see less access perhaps to some of the social services. We need to keep in mind for engagement, because in the South, an area where it has more poverty in general, this population and this risk of higher rates of concomitant disease, as you see here with toxo, are going to become more and more relevant. Efforts to improve this by offering financial outcomes that were done by a great study by Lisa Metch, published about 2 years ago, and Carlos Del Rio, were not successful. You showed no benefits in the patients who were on the program versus were not. And so we need to have strategies other than financial incentives. And I think looking at some of the root causes of this issue, and then having persistent support of patients, are going to be the only way we're going to be able to get around some of those. And that completes our presentation for today. You will receive an email with instructions to fill out our post-test evaluation. Susan has asked a question. Why don't we unmute before we're done? We still have about 5 minutes left. Susan, what was your question there?
So I think we've got a group of providers here who have interest in dealing with the issue of folks who are in the Southeast, and how do we get more providers up to speed there?
Up to speed in terms of HIV and
In
the
terms
risks
of
we're
HIV,
talking about?
right, treatment.
Yeah, it's an important question. I'd say it's got to be on multiple levels. First of all, we have to start on a college level, helping people to understand what health inequities are and social determinants of health. That's got to continue in medical school and residency. So I think it's got to be an effort that is permeating throughout the educational system. Then I think one thing we've seen in DC, and you know this, Susan, is that we have to have 10 credits for CME a year, maybe it's less than that, 4 credits. I can't remember the exact number, but a certain amount of credits that are particular just to HIV. So I think if we have, because HIV is such a common issue in the South, if more states would adopt an HIV CME need, then there'd be more education around that. And we could also argue that some of those CME needs should be based on social determinants of health, because HIV is not the only disease that's influenced by social determinants. Arguably, most other diseases are. And so I think that's a second area. And finally, we talked a lot about obesity today. Obesity is clearly an issue that spans both the issue of social determinants, but also just health literacy and health education. And so all of those things are going to be important. This is a tall order right now in the midst of COVID. Living within a pandemic and talking about the preceding pandemics that commingle with your existing pandemic, it's overwhelming. And so it's going to take a lot of skill and a lot of consciousness to help reintegrate and educate our population.
I think the pandemic also gives a particular opportunity. Everything's moved online, and you're right, we're going to have to work on the education level. And as you know, I've been working on that for a long time, as are others in the room. But I think, too, with things moving online, we have an ability to reach parts of the population maybe that were harder to reach before. So I don't know. I think we'll have to think creatively about that.
Oh, I think it's true. I mean, one of the things I can tell you with telemedicine is I don't have canceled visits.
Right, me neither. It's amazing.
Which is good and bad. I mean, at the end of the day, those full schedules stay full, and you're exhausted at the end of the day. But you're right. In rural areas where patient transportation was an issue, that's going to cease to be as important. And I think we're going to have to figure out how to leverage telemedicine better, and how mobile-based phones are going to be a vehicle to have a doctor visit, not necessarily coming in as much. And we're going to have to figure out how to leverage that. So we're getting near to the end of our time. So please make sure that you fill out that self-report form and that you do everything to get your certificate. That's important for your CME. My God, thank you guys for coming out on the holiday. I hope we made this informative and at least a little bit educational. Thank you guys. Have a great rest of the day, and good luck and Godspeed in the rest of your work. Bye-bye now.
Thank you, Dr. Elion.